Hello, my name is Jonathan Finoff, and I'll be talking to you today about ultrasound-guided interventional procedures of the ankle and foot. I don't have any disclosures that are relevant to this particular presentation, but I do have a disclaimer. This presentation is not meant to be a comprehensive review of all procedures at the foot and ankle. Rather, the objective is to cover the core competencies as outlined in the AMSSM recommended sports ultrasound curriculum for sports medicine fellowships. With that in mind, I'm going to cover injections into the ankle joint, the peroneal tendon sheath, and the plantar fascia. So starting out with intra-articular ankle joint injections, I'm going to describe one particular technique in this area in which the patient will be placed in a supine position with their knee flexed about 90 degrees and their foot flat on the table, so their ankle is in a slightly plantar flexed position. A high-frequency linear array transducer will be placed over the anterior aspect of the talus so that you can see the talar dome. The needle for this procedure will be a 25 gauge 2-inch or 25 gauge 1.5-inch needle depending on the size of the patient. And the needle orientation relative to the transducer will be in the long axis or longitudinal, so this is an in-plane technique. The needle will traverse from a medial to lateral direction deep to the anterior ankle tendons and the adjacent neurovascular structures. So in this particular picture, medial is on the left of the picture, lateral is on the right of the picture. So here's the tibialis anterior, extensor hallucis longus, and extensor digitorum tendons, the deep peroneal nerve and dorsalis pedis artery are going to be just deep to the extensor hallucis longus tendon. This is going to be the joint capsule and periarticular fat with the underlying hyaline cartilage and talar dome. The needle will go from a medial to lateral direction and will go deep to the capsule and superficial to the articular cartilage. Again, from a pearls and pitfalls standpoint, you really want to identify and avoid the deep peroneal nerve and dorsalis pedis artery and veins. For the peroneal tendon sheath injection, the patient will be placed in a side-lying position with the symptomatic side facing towards the ceiling. I use a high-frequency linear array transducer. A short footprint linear array transducer would be ideal. And typically, I'll use a 27 gauge 1.25-inch needle. The transducer will be placed in an anatomic transverse plane over the peroneal tendons near the level of the lateral malleolus, which is in the area of the common tendinopathic region for peroneal tendinopathy. The needle relative to the transducer will be oriented in a long axis or longitudinal, and this is an in-plane approach. The needle will traverse from an anterior to posterior direction. So in this picture, if the left of the screen is anterior, the right of the screen is posterior. Here's the peroneus longus and the peroneus brevis tendons. The superior peroneal retinaculum is attaching to this fibrocartilaginous triangle in this region, and here you can see the retinaculum coming over the top of the tendons. Here's the lateral malleolus. And so the needle will traverse from anterior to posterior, and it will go deep to that superficial peroneal retinaculum and inside the tendon sheath and inject around the tendons. There are no significant anatomic structures that you need to be aware of. The sural nerve, which is more posterior, should not be in play in this injection, nor should the superficial peroneal nerve. A perifascial plantar fascia injection, I'll have the patient in a side-lying position with the symptomatic foot in the dependent position. I'll use a high-frequency linear array transducer. The transducer will be placed in an anatomic transverse plane over the plantar aspect of the calcaneus such that the plantar fascia can be imaged. I'll use a 25 gauge 2-inch needle or 25 gauge 1.5-inch needle depending on the size of the patient's foot and ankle. And the needle will be in a long axis or longitudinal plane relative to the transducer, so this is an in-plane technique. And the needle will be traversing the tissue from a medial to lateral direction. So in this picture, this is medial, the left of the screen. This is lateral. Here's the calcaneus. The plantar fascia is this hyperechoic tissue sitting on top of the calcaneus. This hypoechoic line is the plane in between the overlying fat pad, which is superficial, and the plantar fascia, which is deep. And so the target is going to be in this hypoechoic plane, right in that region. You want to avoid injecting into the plantar fascia if you're using a steroid, because this can predispose to rupture. And you also want to avoid injecting into the overlying fat pad, because that can cause fat pad atrophy, which is a significant complication with this type of procedure. You also want to identify and avoid the medial ankle neurovascular structures, since you're going to be taking a medial to lateral approach, but typically they are not in play with this procedure. For an injection into the fascia, you can either do this in the same approach described for the perifascial injections, or alternatively, you can use a proximal to distal or distal to proximal approach with the transducer in plane with the plantar fascia. And that completes the common procedures of the foot and ankle.